All right, I think we'll get started just so we don't cut into any time for Padma, who will be giving the talks today. Oops, I know I just covered up my camera, sorry. But welcome everyone. My name is Sandy Davidge. I am the Executive Director of the Women and Children's Health Research Institute. So I'd like to start off in a good way by acknowledging the land where I'm joining you from Treaty 6, which is colonial known as Edmonton. Treaty 6 territory is a traditional gathering place for the diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others. As we are meeting today virtually, I invite you to take a moment to think of and give gratitude to the peoples of the traditional territory from that you are joining from today. So I think we should all reflect on that for a moment. And I say we're joining from other areas of the country because I'd like to introduce you to Partnership of Women's Health Research. So this workshop is today hosted by the Women and Children's Health Research Institute here at the University of Alberta in Edmonton, also known as WCHRI, and along with the Partnership of Women's Health Research Canada, or PWHR. PWHR is a national alliance to catalyze and coordinate the promotion of women's health research, of which WCHRI is one of the founding sorry, I keep on covering my camera, for which WCHRI is a founding partner. So PWHR's vision is better health for all women, trans, and non-binary people through research equity, excellence, and inclusion. The 4 partner research institutes that you can see here on the map are the Women's Health Research Institute in BC, British Columbia, WCHRI here at the U of A in Edmonton, the Women's College Research Institute in Toronto and Ontario, and IWK in Halifax in Nova Scotia. Leveraging our resources and expertise to raise the profile of women's health research, to offer national networking and mentoring, and to offer training opportunities such as this workshop here today. So thank you for joining us here today. So I would like to now introduce our speaker. So our speaker is Dr. Padma Kaul, and she's a professor in the Department of Medicine, and she'll be speaking on the value of birth cohort studies, assessing the impact of exposures on long-term outcomes. Dr. Kaul has many hats and many titles. She is a member of the Women and Children's Health Research Institute, but she wears a lot of leadership roles. She is co-director of the Canadian VIGOUR Centre and an adjunct professor in the School of Public Health at the University of Alberta. She's the Canadian Institutes of Health Research Sex and Gender Science Chair and holds the Heart and Stroke Foundation Chair in Cardiovascular Research. Dr. Kaul's research interests include international differences in practice patterns and outcomes, sex differences in treatment and outcomes of cardiovascular disease, long-term chronic disease implications for pregnancy-related complications, as well as issues related to access, delivery, and cost of care at a population level. So many hats, many categories, but always with the sex and gender, women's health as a part of that background that Padma brings. So without any further ado, I'd like to introduce Padma Kaul, and thank you again, Padma, for putting on this workshop.
Thank you so much, Sandy, for that introduction. You can hear me and see my slides. So without much ado, I will get going. I have no disclosures for this talk. So I just want to start by saying that increasingly the research community and policymakers are recognizing the importance of pregnancy as oracle, or what it tells us about the future health of not only the mother but also the baby. And these are guidelines that the European Society of Cardiology as well as the American Heart Association have released about the importance of pregnancy and heart disease in the woman. And I want to, regardless of how many hats I wear, my training is in epidemiology. I'm a population health epidemiologist, and as many of you who are trainees who are still going through your research and your getting your degrees, you all know that the types of epidemiological studies can be nicely articulated in this pyramid of evidence. And what I am going to talk to you about primarily is cohort studies, which are the really almost the only way, observational studies are the only way to look at pregnancy and long-term outcomes. And cohort studies, brief refresher course for all of you, these are non-randomized. You have an exposed group and a non-exposed group, and then you can see how many develop the disease or condition of interest versus those who don't. And just briefly, that they can be retrospective in design, which means that they started in the past and the outcomes have occurred in the past. Or they can be prospective, which is you start them now and follow them forward. And there are issues with observational studies and cohort studies in particular, because you have to be aware of internal validity as to whether you're capturing your target population, whether they are generalizable to any other populations other than the ones that you're observing. And then there are issues with selection bias, measurement bias, but then these are things that have to be very carefully accounted for when you develop and analyze cohort studies. And then there is the issue of confounding, and that there is a huge issue with because these are observational in nature, that it's not just a coincidence that you're observing versus a causation. And you have to be very careful about accounting for confounding. So the topic today is about pregnancy birth cohorts, and I want to talk to you about two designs, which is the prospective pregnancy birth cohorts versus the administrative health-based or population-based pregnancy cohorts. You all may be familiar somewhat with some of these really established prospective pregnancy birth cohorts, such as the CHILD study, which started in 2008, and it recruited women who were pregnant in 4 cities in Canada. And they're trying to understand the genetic and environmental determinants of disease, such as asthma, allergies, etc. Similarly, All Our Families is an Alberta-based pregnancy birth cohort, again, around the same time, 32 mother and infant dyads, and looking at prenatal and child development issues. APRIN, which is focused on maternal mental health and child development. And more recently, there are several. In Alberta has a rich history of pregnancy birth cohorts, from the Bloom study looking at early microbiome to the cannabis exposure study called CAN-CAN. And Amy Metcalf co-leads the preterm birth, or the P3 cohort set in Calgary. And of course, there's the iHealthy project, which has just started recruiting, which is looking at Indigenous health trajectories. So those are prospective cohorts. As I mentioned, my interest and what I do, really, my research is focused on developing pregnancy birth cohorts using administrative data. So I'll come back to this slide multiple times, but really the Alberta Pregnancy Outcomes Birth Events, or PROBE registry, links data that are administrative in nature, but how they can be utilized for research purposes. So for those of you who are not familiar with administrative data, these are data that are generated at every routine encounter with the healthcare system. So hospitalization records, outpatient clinic visits, physician office visits, pharmaceutical claims. That's what composes administrative data. They are administrative in nature, as in they were never meant for research purposes. They were more developed for reimbursement, billing, budgeting. But as you will see, they can now be repurposed for research and surveillance. There is a standardized coding of these databases, the ICD codes that the World Health Organization releases. We are currently using ICD-9, version 9, and ICD code version 10. There is ICD version 11 coming. In fact, some of the European countries have already started implementing it. It's so complex that I hope to be retired before we start using it in Canada. And as I mentioned, it can be used for research, health services research, surveillance, monitoring health outcomes at the population level. These are the most common administrative databases: the discharge abstract database of hospitalizations, the NACRs of outpatient clinics, practitioners' claims, and population registries. So the registry gives you information on migration patterns, sociodemographic information, and this is collected annually. And this is, these are the data that are available across provinces and, so if you want to look at studies across Canada, these are available in all provinces. I want to just mention to you that there are obviously pros and cons of the prospective cohorts that I described earlier on to the population level, cohorts that we're going to talk about. While the strength of the prospective cohorts is you can collect specific data specific to the research question of interest, such as biological samples. You can collect detailed history, you can collect detailed survey data. They do suffer from selection bias, and they're very expensive, both in terms of time and in dollars. There's the issue of loss to follow-up. And sometimes, in fact, most times, they're not adequately powered to examine other associations. So if you wanted to say, look at ethnicity or something specific like that, they may not have enough numbers to examine those. Whereas at the population level, the cohorts, they can answer, once you develop the cohort, they can answer multiple questions. However, on the other hand, they do suffer from the issue that you don't have enough clinical detail. Like, it's hard to get information on blood pressure or height and weight in these databases. They are dependent on coding practices. However, they have the strength of being completely, no selection bias because you're capturing data on everyone. They're inexpensive. There's a way to follow all patients till they leave a certain jurisdiction. So there is a reduced risk of loss to follow-up. And this is really, the population health databases are the only real way to examine rare diseases. It's just not possible to do it any other way. So some of the limitations that I talked to you about population health databases in Alberta, we've had an opportunity to actually address them by layering on additional data sources. So the ones I want to focus on are, we have prescription drug claims for everyone, linked in as of 2008 to the pregnancy birth cohort. We have labs centralized that are linked in as of 2012 for the entire province. I'm particularly happy about the fact that we've been able to link with public health data, the immunization data, not only because you can then track what's happening in terms of immunization status, but the immunization data also give you really key information about breastfeeding and what the baby has been fed at each of the points at which the kids have immunizations, which is like 2 months, 6 months, 12 months, 18 months, and then preschool. And then we have used these data to track what's happening in terms of BMI, because height and weight of the babies, of the kids, are measured at each of these points. They do an assessment of postpartum depression at the 2-month visit. So there are some key data that we have been able to link in Alberta by linking with the population health, with the public health data. So this is the cohort that we currently have access to. As you can see, it started in 2005. And the reason we started that late is because as of 2005, there was a you couldn't discharge the mother and the baby from hospital without assigning a ULI. So there is a deterministic linkage between the mother and baby. And we have been following these women, which currently, as of 2023, we have 500,000 women in these data in the probe data registry, and with about 12 years of follow-up. And it includes data on about 900,000 babies, and the median age of these kids is about 8 years. It also includes data on 4,000 stillbirths in the province. So I just want to just scroll through some of the work that we have done using these data, and then maybe, you know, answer questions when you at the end of this session. So my postdoc Delhi has looked recently, which was published, looking at complications of pregnancy, namely gestational diabetes. Overall, as you can, this is diabetes and pregnancy prevalence. And you can see in the red, this is gestational diabetes versus type 2 diabetes, so pre-existing, and pre-existing type 1. And these are trends over time in Alberta, and not just overall, but also in specific subgroups. Of course, you could take the data. We're very interested in putting what's happening in Alberta in the context of what's happening around the world. And so this is our PhD student who came from Denmark and came and spent a research rotation here, looking at what's happening in Alberta and comparing that to what's happening in Denmark. And there's a strong collaboration between the two countries to look at questions like these. Because the Alberta data are so unique in terms of having all the labs for the women linked in, we have been able to do things that others have not been able to. For example, this is a study which has looked at how many women, pregnant women, get screened for gestational diabetes in the province. And as you can see, well done, Alberta, because about 94% of all women who are pregnant do get screened for gestational diabetes, which is incredibly, I think, one of the highest in the world, because when we've compared it to other countries who have these data, our rates are much higher. We can also track them forward and see that whether they are, for those women who were diagnosed with gestational diabetes, which is a condition that is supposed to, by the end of the pregnancy, is supposed to resolve, but these women are really high risk for developing type 2 diabetes down the road. We wanted to see the guidelines recommend that they get screened within 6 weeks to 3 months or 6 months. And we wanted to see how many of them get screened after the baby is born. And as you can see, we have a lot of work to do in this space, at least, where only 55% of the women underwent a screening for diabetes within 1 year. And then we can also, because of our linkage with the prescription medication data, we've been looking at how what kind of treatments these women, the women with GDM, are getting in Alberta. We can, as a result of, it's not perfect, but using naming algorithms that were developed by Huda Kwan in University of Calgary, as well as Beju Shah in ICES in Ontario, we were able to apply those and kind of look at what's happening in women of South Asian descent or of Chinese ethnicity in Alberta and in British Columbia. This research was led by our faculty member who's an endocrinologist, Rose Young. As I mentioned, one of the biggest benefits of the population health pregnancy birth cohort is that we can follow the women as well as the children longitudinally. We are looking to see how many of the women with complications, again, this is with GDM, where we group them according to their weight status and GDM status into 4 groups. And you follow them, for a median of 5 years to see how many of them converted to type 2 diabetes, how many developed chronic hypertension, and how many had coronary disease. As I mentioned, one of the strengths, and maybe the only way to look at rare conditions during pregnancy, is through these population health databases. So trainees of mine have looked at syncope in pregnancy and neonatal outcomes. It's about 1% prevalence of syncope, but then we have shown that when it occurs, whether it's the first trimester, second trimester, or third trimester, has an impact on the outcomes in terms of neonatal outcomes, but also in whether the women come back for arrhythmias in the 1-year follow-up to the pregnancy. Peripartum cardiomyopathy is, again, a very rare condition, but it has huge implications for both the health of the mother as well as of the baby. And so we have looked at that again with Suman Desi, who is a clinical trainee working with us. Sarah Goldstein was a trainee from Duke who worked with us and is now on faculty at Yale. And her interest is in looking at women with congenital heart disease. And we've been looking at what the implication of preeclampsia in women with and without congenital heart disease, and with and without preeclampsia, and what the outcomes are in terms of pregnancy outcomes are in these high-risk groups. Stephanie Keeling is a rheumatologist who's interested in the impact of these conditions on peripartum outcomes in this high-risk population, and we are developing a program of research looking at what drugs these women are taking and what the impact is on neonatal outcomes. A huge advantage is that we are able to link the mother to the baby, as I mentioned. And so we have a huge program of research looking at outcomes in the kids as well. So this is a study where we looked at the economic impact of low birth weight in Alberta to see how much low birth weight infants cost the healthcare system. And then with our collaboration with Dr. Ball, who is an expert in obesity research, we are looking at the prevalence of childhood obesity in Alberta. I want to remind you, when I showed you the picture of the Alberta population health data, that the immunization data has BMI. So that's the source to link. And then to see what's happening in terms of obesity rates in Alberta. This kind of is a summary of all the projects that we're doing in this space using the linked data. So we're looking at maternal pregnancy factors and the outcomes on kids' health. So as I showed you, diabetes during pregnancy, we have a project looking at opioid use by the mother and what the impact is on kids' outcomes. We can look at C-section induction as well as breastfeeding and look at, there's all the interest about how that impacts the microbiome. So, what's happening to obesity in the kids. We're absolutely interested in the social determinants of health, which these data really support. Through the linkage with census data, we can look at material deprivation, I showed you data on ethnicity. We have information on immigration status of the mother. It's not perfect. None of these are perfect. There are definitely some limitations, but you know, they give you an idea of what additional research needs to be done and what where we need to focus. We are looking at early childhood factors such as breastfeeding, what the birth weight was at, and how that, what the trajectories look like. We're looking at antibiotic use during the first 2 years of life and how that impacts obesity outcomes. The built environment is really exciting to us. It's a new area, but we just got a paper in looking at things like distance to playground, distance to major parks, distance to schools, and intersections and walkability indices, and how that impacts the incidence of obesity in kids. Of course, because the data are administrative, one of the things that you can definitely use them for is to track economic outcomes, because that's kind of the purpose. And so we have, as I showed you, the low birth weight, we've been looking at the economic impact of that. And now this is a study that we've done with our colleagues, pediatric cardiologists, looking at what the cost of care in kids with congenital heart diseases. So I want to just briefly switch tracks and talk to you. So all the data that I showed you till now was focused on Alberta, which has one of the richest data sources, and through the integration has phenomenal research resources to do pregnancy birth outcomes research. However, obviously this is not unique to Alberta, and it is true of all the provinces. And CAMCO, the Canadian Mother-Child Cohort, is this national research network. The nominated PI is Dr. Berard from the University of Montreal. And each province has a provincial PI, and our goal is to bring these pregnancy birth cohorts from each individual province and put them together so that we can create one of the largest, if not the largest, pregnancy birth cohorts. With the Quebec cohort, I think, is the oldest, with up to 28 years of follow-up. But, data on 10 million pregnancies, and, talk about rare conditions, talk about validation. So, this is a really rich source. So the CAMCO research has been funded by CFI, as well as seed money from CIHR. And its major focus is looking at the impact of prescription drug use during pregnancy. When we looked at the data initially in Alberta, I was personally shocked to see that 68% of women who were pregnant had at least one prescription claim during pregnancy, which seems awfully high. And this really pretty picture on the left shows you the kinds of drugs that these women were on. But I mean, if you think back, if you take a step back and you look at it, pregnant women, as you know, are systematically excluded from clinical trials. Many pregnancies are unplanned, and we do know that the characteristics of women giving birth in Canada is changing. I mean, we are older, perhaps heavier, definitely have more pre-existing chronic disease. So the probability of exposure to medication during pregnancy is increasing. So basically, the CAMCO objectives are to put in place these population-based cohorts in Canada. We currently have the 5 provinces and we are working with BC and Nova Scotia, and to get a surveillance system to evaluate and identify safety signals, and also to assess use, safety, and effectiveness of drug therapies, because we have really no other evidence other than this observational data. And as part of CAMCO, what we want to do is to develop standardized and harmonized tools. So have a common data models, definitions, codes, algorithms that we want to make available to researchers across all the provinces, and be able to share code and algorithms. And then once the data are run across all the provinces, we aggregate the data in terms of means and prevalence and risks. We do want to develop new analytical methods, including machine learning methods. And of course, the major goal is to train the next generation of perinatal scientists. So this is kind of basically is a graphical representation of what I just described to you, that the jurisdiction, as you know, the data do not leave the provinces. So the analyses are done in parallel. However, the codes and the definitions are shared across the group, and then the data are aggregated. So for those of you who are interested, the first paper from the CAMCO just describing the cohorts and the group and what we are doing and the goal has been published, and I would encourage you to maybe review that if you're interested in collaboration. What the paper looks at is just generally preterm birth and low birth weight across the provinces, major malformations in first year of life, by organ system. And also some of the projects that we have already completed include from Health Canada an interest in cough and cold products containing opioids and what the utilization patterns were. And so each of the provinces has provided data, and the manuscript is the report is complete and the manuscript is under review. So we have provided the types of OMCCs by province and age group, trends in the use by province and age group. And then, so one of the other projects as part of CAMCO that we have just have completed a while ago is looking at COVID-19 in pregnancy and what is, what the exposure to COVID-19 what impact it has had on neonatal outcomes. As I mentioned, that the volume of data is getting so huge. We're definitely in the realm of big data. These are kind of old, and even if you total up just in Alberta, you're looking at 68 million data points. So it's incredible, and I think we need new ways of analyzing these data, and we are definitely interested in doing big data analytics. I don't have time to show you this. But one of my PhD students is looking at, if you click on this link, it's a tool for clinicians to get information about the use of drugs. So if the clinicians have a patient whom they're considering to put on, say, beta blockers, or there's a drop-down box, and it tells gives the clinicians set information: how many women, which trimester, what were their outcomes, how many had preterm birth. So the point is to in addition to their own clinical expertise and guidelines, etc., what we want to do is to provide data at their fingertips to inform clinical decision-making. Other ongoing projects as part of CAMCO is looking at atrial fibrillation in pregnancy, so a rare condition led out of McGill, looking at anti-epileptic drugs in pregnancy, led out of University of Manitoba, asthma medications and their impacts. Jennifer Conway, who's a pediatric cardiologist, is interested in using the CAMCO infrastructure to look at cardiomyopathy in children. We are looking at the social determinants of health and CHD incidence, Dr. Hornberger at UFA. And as I mentioned, Stephanie Keeling is continuing her work looking at pregnancy in women with rheumatic diseases. I do want to make a plug that the CAMCO research infrastructure then was successful in getting one of the CIHR HRTPs, the training platforms. It's called CAMCO-L. We have done 2 cohorts, and it's a 5-year project. So we will have multiple and will be sustained, hopefully, on an ongoing basis. In addition to CAMCO-L, we were also successful in getting CAMCO Outreach, which was one of the KTKM hubs for that were recently funded, I think, last year. So the key takeaways, as I finished the CAMCO part of the presentation, is to say we are really committed to building capacity and training the next generation, and to building a Canadian consortium of researchers who want to work in this area. So I do want to encourage all of you to contact. Just go to the website. If you go to CAMCO website, find either your provincial lead or reach out to me for sure, or to Dr. Berard. We really want these data to be used and this infrastructure to be used, and for Canada to do excellent work in this space, which is in perinatal research. So I just want to come back to the fact that we saw these trends and weaknesses that I mentioned of the prospective and the population health cohorts. But what I want to finish with is talking to you about a One Child Every Child, which is a recently CEFRA-funded investment established at the University of Calgary, but WCHRI and the University of Alberta are major partners of this initiative. And it has an opportunity to perhaps combine prospective and population health cohorts. So this is the structure of One Child Every Child. It has 3 themes and several cross-cutting accelerators. And as you can see, the outcomes of interest are research excellence and breakthroughs. And again, the theme of next generation of scholars, with a very focused view, or with a focused interest in EDI framework and action plan, and hopefully, and also to transform health outcomes, or working with Indigenous peoples to promote health and improve outcomes. The 3 themes: the better beginnings is the major focus that Dr. Metcalf at the University of Alberta and myself are facilitating, which is to address challenges impacting the health and well-being of mothers and babies. And as I mentioned, one of the major areas we want to work on is to bring the cohorts and the administrative pregnancy birth cohorts together. So the planned integration at the bottom, you can see, is to bring the Alberta-based cohorts such as All Our Families, Apron, iHealthy, the pregnancy during pandemic, all these individual cohorts that have a rich data in terms of biosamples and survey on exercise, on diet, etc. Bring those all in and link them to this common data model that I just showed you with the administrative data. And by collating all these together, give researchers, especially our trainees and other researchers, early career researchers, the opportunity to, have that larger access to that larger cohort so that they can address some of the questions that are not possible to address in the individual, using the individual cohorts. So this really just restates what I just said, which is to create an inventory of cohort-specific resources and map them and see what's collected across multiple cohorts. So if I am interested in ethnicity and GDM, maybe each cohort I cannot use to answer because the numbers are not enough. But if I pool the data across all the cohorts, I might be able to address that. As I mentioned, parallel paths, we're really interested in developing Indigenous-led projects in this space, in the pregnancy birth space, and the parallel paths are really integrated into the vision of OCEC. I just want to end on this note that which I truly believe, without data, you're just another person with an opinion. And I think that, what I've shown you, I hope you will see the value of using data and the availability of the fantastic resources that are available in Canada to do this kind of research. I want to thank all the sponsors who have made our research possible, and I'm happy to take any questions, and hopefully I've not run over.
That was fantastic. Thank you, Padma. Outstanding. I have some questions, but let's maybe stop sharing so we can, there's a small group here today, so we can hopefully make this more like a workshop-y type of discussion. So all of you, whoever has any questions, please show up and either put it in the chat, or better yet, raise your hand and just verbalize it yourself. And we already good. I don't even have to come up with the first question, although, like I said, I have lots. But go ahead, Laura. You're on.
Thank you so much, Dr. Kaul. That was very, very enlightening. And one of the questions that I have, if you already told that to the audience, please forgive me. But I was thinking about ultrasound findings during pregnancy. So I would like to know if you have that data in.
Excellent question. And it is, I just showed you the first priority as part of OCEC, the programs that we are planning. And one of the second, we have 4, and one of the 4 is to develop AI models using fetal imaging. And so really thrilled to say that one of our pediatric cardiologists just got some funding to look at fetal echoes and looking to see how we can use the AI methods to for diagnostic purposes for congenital heart disease using the fetal echoes. And so I think that we will, that's the first project, but we do want to keep adding, right? Like the vision is to link all the data. Now the imaging is the biggest additional one that we want to layer on to the pregnancy birth cohort. And, stay tuned. Yes, that is the goal, is to go down in the future.
Camille, our executive director of Power. So.
Thank you so much, Sandy and Padma. That was an excellent talk, and I really loved the beginning and just found it so useful how you walked us through the different types of studies. I think that we are recording, and this will be an ongoing useful resource for trainees. So I have 2 tangential questions, I think, but you're an expert, an international expert in this space. So you mentioned the World Health Organization, the new ICD coding and its complexity. So I thought I wanted to ask you, okay, it's more complex. What is it going to give us? What are the benefits of that new coding? So that's one. And the other one is about the CAMCO platform. I'm sure you're very much aware, we don't have a national maternal mortality review in Canada. And this is something that SOGC, as well as many of the stewards of the perinatal databases, have been interested in for a long time. And I'm wondering if there's been any conversation about how the infrastructure of CAMCO might be used to contribute to moving that forward. Thank you.
Okay, two excellent questions. The first one about ICD-11. Yes, well, I'm aware, like, you know, their codes, you can get finer and finer in terms of, you know, the level. So let's take a big one, which was a huge step, was if you talk about diabetes, the fact about, you know, after one version, you could now track whether it was type 1 or type 2 and what, you know, all the various kinds. And I'm talking about that was done like, you know, decades ago. The 11 is, I think, going to get even more fine in its detail. The presentations I've been to, the detail is so fine that I'm like, oh my God, I don't think I want to deal with this level of, but I don't know when. I know it is coming. I don't know when. As you can imagine, getting it implemented is a huge deal. So I think there's going to be a huge runway. That's why I kid when I say I think I want to be retired before it comes into practice. But no, I think it will be great value, because we have definitely, I think, you know, established how useful these data are for certain kinds of things, maybe not to address clinical questions, but definitely for surveillance. So, and, you know, rare diseases, etc. So I think that it will definitely be of value when it comes through. Your second question was about CAMCO. Yes. So I'm sure you're aware of the HRDN, which is the Health Research Data Network. I mean, it's also trying to bring together the data. But I think that projects like CAMCO are going to be really key, because you could see right now, because this predates the HRDN, you know, platform, we've done it by bringing together the researchers from each of the provinces. It's a collaboration, etc. But you could think that going forward, we could collaborate with the HRDN, but we still have the experts who are working in this field. And so when there is something that Health Canada or Public Health Agency of Canada have a question that is in this space, that they could turn readily to CAMCO, which is primed and ready to run with it. One of the projects I showed you briefly was the COVID-19 project. And, you know, you couldn't have done that without CAMCO. I mean, can you imagine starting from scratch when we're in the throes of the pandemic? It would have been a disaster. But because we're all ready and have resources in place, we were able to turn it around so quickly. So I think that is going, the responsiveness and our ability to act quicker is going to increase as a result of having networks like CAMCO already in the space. And I think going forward, one of the grants that I was talking to you that didn't get funded when we started this conversation is looking at using the CAMCO infrastructure, but looking at it nationally in the gestational diabetes space as to what these women are getting treated with. Now, again, so the goal there is to bring together a clinical network that is pan-Canadian with a data network like CAMCO, and then, you know, trying to move the evidence forward. So I think that there's a lot of value. Of course, I could be biased, but I think that there is a lot of value to this kind of infrastructure.
Thank you very much, Padma.
Well, then I have a question. It kind of goes back to that infrastructure and then how and who can access it. So I'm a basic scientist. If I needed RNA-seq done today, I wouldn't do it. I would bring it to a core facility. It would get done. Then you go to your bioinformatics, and then you have the data to understand how it fits and works with your interpretation. So same thing here. How do we, it's because this is a workshop, right? Here, and you have the HRTP platform, but how do you open it up to more interdisciplinary people who have questions, but aren't big data and not statistically savvy enough to deal with it? And how do we open the doors that people with great questions can ask it and get good data and get good data in and good data out? Could this be a platform where I sit there and say, hey, can you tell me how many boys are born from GDM versus normal pregnancy or uncomplicated, you know, something's, how do you see a visionary of, we're not going to train everybody to be epidemiologists. How do we make a platform that's easy access?
Yeah, no, so I should just say that there is no point in developing and putting so much investment in these in an infrastructure like CAMCO if it is only going to be useful for the 7 provincial PIs or whatever who, you know, came together. I think it's completely not efficient. The whole goal is to put in the infrastructure so that it can, you know, serve the needs of the larger community of researchers. I mean, otherwise, I don't even know why we're doing this kind of stuff. So to that question, I think there is incredible, the vision is to make the data available for researchers. And so how do you do it? As I mentioned, I think it is just contacting. We have, I cannot think of one project where we have said, no, we're not going to do it. I mean, we will be able to tell you right away, yeah, the data are there to address this question, or they're not there. You can't do it, or you can only do it in province X and Y. So, you know, that right away we can direct you because we know the data backwards and forwards. How do you do it? Yes, I mean, this is the thing, is that many of the projects that I mentioned that are underway in CAMCO are led by clinician scientists. They're not going to have the expertise to know admin data. No amount of workshop attendance is going to get them there to analyze the data. Just like I can't do your RNA sequencing, you know, so I do. So the goal is to put in resources that will support that research. So I think the thing is, bring us your best questions and we will help you answer those questions. Do you know what I mean? That's the goal, Sandy.
So people could go to your website, a CAMCO website, or eventually a One Child, Every Child website when we get enrolled.
Correct.
Yep. Okay.
Correct. Yeah.
Excellent. Well, this was great. Really fascinating. Like I said, we will be posting this talk so that other trainees can actually be able to see it if they weren't available today.
Yeah, and to the extent, like I talked to you about the CAMCO HRTP, you know, that's a ready one that if the trainees, it's great exposure. They meet, you know, trainees in the same space, and we have a collaboration where we take them to Europe and talk to WHO. So I mean, it's a great training platform. We have a whole array of tools, techniques, experts giving you know, information to the trainees, including the Alberta Machine Intelligence Institute runs a program on ML and how it can be machine learning and AI and how those tools can be used. So it's a great training platform, and I would really encourage people to apply.
Excellent. Great.
If I had time, I would do it.
That's a great way to end. So thank you, Padma. That was amazing. Really, really appreciate the time and effort you did for us today, and to enlighten everybody and to know that there's all this data out there to continue to work with. So thank you. So the last slide here is one just to kind of plug the next series that will be happening. So please join us and Power at the next event on March 1st, and it's to celebrate International Women's Day with a panel that features, you can see the investigators here. I'll put a plug in for Dr. Carla Prado because she's here at the U of A and WCHRI's hosting today. But they're all going to be amazing speakers. These are amazing researchers and the leading women's health researchers from across the country. So please go to the Power website to learn more about this event that's coming up March 1st and to register. And hopefully we can see everybody at the next event together. I'd like to thank the whole WCHRI team and Tamil and the Power team that allowed us to go on today. And once again, thank you again, Padma, for the great talk. And thank you for sharing all your wisdom. And hopefully you'll see more people knocking at your door. You have Hey.
Happy to do that.
Well,
Thanks.
thank you, everybody. This was great. We'll see you soon.